Hey guys, welcome back. Another episode of the Shift Brief here with my good friend, colleague, Stephen Burke. If you were watching the last episode that we did, we were talking about strokes. It's a pretty comprehensive conversation, but yeah, here we are talking about seizures. So Stephen's background, he's a neurosurge nurse, critical care nurse, and critical care flight nurse. And yeah, now we're going to talk about seizures, and specifically grand mal tonic-clonic seizures, because there's a lot of different types of seizures.
There's a ton of different types.
Steve and I are having a conversation kind of offline here, and Stephen, let's talk about seizures. And in typical neurosurge critical care nurse fashion, Stephen's like, what kind of seizures, Joel? There's a whole lot of seizures.
There's a lot of them.
Let's talk about one. So we're going to talk about tonic-clonic seizures.
The big one.
Yeah. Pre-hospitally, it's something paramedics see often. It's a very common type of 911 call. So whether it's a pediatric seizure being a febrile seizure, first-time parents have never seen it, or parents seeing a seizure for the first time in their child. Right. It's a very common one, actually. Mm-hmm. Often we're going for epileptic patients with a seizure history, and they're either around somebody that's never seen them seize, or they're having an atypical seizure, so it's lasting longer, it's presented differently, and their family's a little concerned about them. Yeah. So, Stephen, do you want to just kind of explain to everybody what a seizure is, specifically a grand mal or tonic-clonic seizure?
Yeah, I mean, a grand mal or a generalized tonic-clonic seizure is kind of when the electricity that's in your brain is not firing correctly, and it's not firing correctly throughout your whole brain,
right?
Which is what causes the generalized tonic-clonic seizure presentation usually.
So kind of like an electrical storm of the neurons in your brain, firing very erratically, and giving you all these different phases of a generalized grand mal seizure. So we've got like an aura phase.
Yep. Some patients have auras for sure. Some people don't.
Okay.
But that's all information that you're hoping to gather from either the parent, if it's a patient that has epilepsy or and isn't able to talk to you, because some of those patients, cerebral palsy, different neurological disorders, they have seizures all the time, and their parents are their biggest advocates. So you're gathering information from them or their care plans. Or you're gathering it from the patient themselves to how does your seizure happen? What happens first? They normally are very well versed in how to report what is about to happen to them.
Right.
Yeah, and so they can tell you a lot from it.
The aura phase kind of being that sense that something's about to happen. So everybody's heard, they smell burnt toast, they're about to have a seizure. That's the joke everybody says. But auras can be anything. It can be, just a sensation. It can be visual. It can be auditory. It can be olfactory. Any of those kind of things. And then often it's going to be followed by the tonic phase. Yes. So the tonic phase being that straightening of the limbs, the hyperextension, the head back, the very rigid phase, almost stiff as a board.
Yep.
Which rapidly progresses into that clonic phase. So that's the rhythmic kind of contracting of the arms, legs, abnormal facial movements. Really scary thing to see. I remember the first time I actually saw one of these. It was before I was a paramedic. I was actually on a bus in the city and had just moved from the country very temporarily before I moved back to the country. I spent a little bit of time in the city, and then I had to leave again because, for obvious reasons, I just don't want to be in the city all the time. Yeah, fair. But this gentleman beside me on the bus started having a seizure, and it was very scary. He was shaking. He was foaming at the mouth. I had to move over a seat because he was spitting all over me. Told the bus driver.
Right into the old clonic phase there.
Yeah, straight. Do not pass go. Straight to the clonic phase. I spoke with the bus driver who had clearly seen a lot of seizures in his time as a bus driver, because he didn't stop. He didn't slow. He looked in the mirror, picked up a phone that was on the bus, spoke with somebody, put it down, and kept driving. And the gentleman came out of the seizure, looked around very confused, which now we know as the post-seizure and the post-ictal phase,
Mm-hmm.
where you're very confused, and then just continued his
On
bus
his day.
route.
Yeah,
And
continuing on his day.
I got off the
He's got shit to
bus
do.
with my head spinning. I had
Yeah.
no idea
Yeah.
what had happened, other than this guy had a seizure. So it was just very strange to see the first time you see it,
Yeah.
and maybe the second and third time you see it. But that bus driver had nerves of steel and was unfazed.
Yeah.
So
Well, he's probably a guy that rides the bus all the time. It's probably like the 10th one he's watched him have.
Probably was. I never got on that bus again. That was it. But most seizures,
Yeah.
are pretty self-limiting. Would you agree?
Yeah, like your tonic phase can usually last anywhere from like 30 to 60 seconds, kind of typically.
Mm-hmm.
And then so there'll be this like tight and stiff, and that's kind of like your warning that okay, something's wrong. A lot of people will say, oh, there's something wrong.
Yeah.
And just as they get their head around, oh, this could be something, then they go into this like your next phase, which is obviously going to be your clonic phase, which can usually last different for everybody.
Yeah.
30 to 90 seconds. I mean, your typical seizure should last around maybe 2 minutes.
Mm-hmm.
And then patient kind of comes around and they settle into your postictal phase, which I think the thing is like to not panic, because like you said, it's hard to watch sometimes, but you don't panic. You do your supportive care and you get them through what you need to get them through.
Yeah.
And then most people are okay after.
Yeah.
You know, I used to work in a seizure monitoring step down unit. So we used to take 2 seizure patients that would come in to have seizures. So they're trying to differentiate where these seizures are coming from. So they would bring them off their medications and they put them on EEG monitoring, and we just wait for them to have seizures.
Right.
And it's kind of one of those things, like the more seizures they have while they're there, the better information you're going to get. So we had to manage a lot, and we've seen a lot of seizures, which is why we don't panic over them now. Right. But when you first see one, like you said, on a bus out in the real world, in your civvies, it's a totally different
100%.
scenario.
I think I had cargo shorts on.
Yeah.
So
That sounds about right.
Yeah. So for any new practitioners, the first time you see this, or the second or third or 10th time you see this, and it's a scary thing to see.
Yeah, it's always scary.
And don't beat yourself up if you're scared.
Yeah, it's okay to be scared.
These patients often will have some kind of minor intraoral trauma. Sometimes they'll bite their tongue, their gums, they'll bleed a little bit. Combine that with a little bit of frothing or foaming at the mouth, then you get this kind of pinkish sputum that'll come out, and it can be pretty traumatic to see, especially if it's coming from their nose. But just know that that's also part and parcel of the seizure pathway. And the other thing that we often see is urinary incontinence. So they're going to lose control of their bladder. Their pants are going to be wet. It's going to be, if it's the first time seizure for them, they can wake up very slow and be very embarrassed by this. So we need to make sure we're maintaining patient dignity too.
Yeah, at the same absolutely. Time. Yeah. It's a scary thing for them for sure.
Yeah. From a treatment perspective, once again, very similar to stroke care that we discussed in the other episode. Once again, starting with the basics, ABCs. Airway interventions are fairly common in seizure patients pre-hospitally. And when I say airway intervention, I don't mean we're jumping in there and intubating patients. I mean maybe some of the manual maneuvers, which were explained in a previous episode that I did as well. So jaw thrusts, head, tail, chin lift, but definitely a jaw thrust if you're concerned of any kind of head trauma. So you're going to protect that C-spine if they had a bad fall and hit their head off stairs, something like that.
Definitely protecting from the hazards for sure. And a jaw thrust if you can get there. Getting them on their side, because they're a lot less likely to aspirate, because you're right, they can bite their tongue, and they can, especially in the clonic phase, they can start to excessively drool and things like that too. So that's putting them at risk for aspiration. So really that like on your side recovery position, hands like on their traps and like protecting their head between your forearms is
Yeah.
like where I usually go for that, if I can have access to the head. So you really want to really protect. That's kind of was our job as nurses, is to kind of make sure that the patient's protected during the seizure, and then intervene if there was a reason to intervene. If they weren't coming out of the seizure, if it was lasting longer than it normally would, than their seizure would normally take, then we would start to intervene with medications and stuff. But most of them are self-terminating.
Okay, awesome. I'm going to come back to that treatment section in a minute, but
Yeah.
if we so we've talked about managing their airway, so those manual maneuvers, probably not going to be able to get an OPA in these guys. Quite often they're clenched, but we do have NPAs.
Yeah.
So we can do bilateral NPAs, support their airway with some oxygen. Quite often they have a very erratic and abnormal respiratory pattern. They're taking ineffective breaths. So making sure we're either getting a non-rebreather or sometimes even a BVM with a good tight seal on there, good mask seal to support their oxygenation and ventilation.
Yep.
These are also patients you don't want to leave your suction in the ambulance for.
Definitely not.
And that was a pearl I passed on in a previous episode. And this, I'm going to highlight it here. If you don't have suction at these seizure patients, you're going to end up in a bit of a nightmare.
Yeah, if I have to take two things to a seizure patient, it's suction and a non-rebreather.
Yeah.
That's if I had to grab two things out of the truck and because I only had like two hands to go, it's going to be suction and a non-rebreather.
Yeah, absolutely.
Everything else is I'm going to use my body.
Yeah,
for the most part.
So treatment-wise, we discussed, and I know, like we said, there's all kinds of seizures, and we're just really scratching the surface on a type of seizure. Benzodiazepines being first line medication for anticonvulsant therapy for patients that are having seizures. Your threshold or your sense of when to treat them, you said in hospital, was if their seizure is longer than it normally is or if it's atypical. But what if you didn't have that information?
Yeah, and a lot of the time pre-hospital you don't.
Yeah.
You need to start getting worried, I would say, after the 2-minute mark. If normally things will start to settle down after a 2-minute mark or like 90 seconds.
Yeah.
So that's when I'm starting to be like, okay, I might need to do something about this.
Yeah.
Or if you're lucky enough to have a monitor on them, and you're lucky enough to have sat monitoring and stuff on them, if this is like a hypoxia that's like not coming up, and like I have a non-rebreather on, you've done the jaw thrust, you're doing the interventions, and you're still not getting a response. And during this time, they're continually it's normal for their sats to drop. That will happen during seizure activity for
absolutely.
sure. So it's not like you're jumping on that right away, but you're jumping on the things that you can do in order to support the airway. And then if the seizure is lasting longer than 2 minutes or the patient has started to hemodynamically become compromised, then we're going to have to start treating something.
Right.
Yeah, because then if you don't do those things, and if you are one of those people that, this patient's having a seizure, and you're grabbing for your treatment from your med bag, then when the seizure terminates, you now have a patient that's under the influence of whatever drugs you've given them.
Right.
So that may end up compromising your airway and things like that afterwards.
Right.
Because the patient's going to be confused. They're going to be lethargic. They're going to be in their postictal phase. So you just have to make sure that you're waiting the appropriate amount of time. And sometimes that's your little, your gut telling you, I don't think this is going to quit.
Right. So for us, for paramedics, we're a little bit more lucky or I should say fortunate in our trigger point to administer benzodiazepines.
Yeah.
Because when somebody calls 911 for seizures, because the patient's already seizing,
yeah,
and we don't have a 2-minute transport time most of the time. So by the time we get there, if they're still seizing, they've been seizing for a while, or they've had multiple seizures. Yeah. So we're going to almost always, once again, do those basic things, get them done quickly and efficiently, but we're going to want to give something to terminate that seizure.
Yeah, your history, again, like we talked about in the last episode, um, is important.
Yeah.
And your historians, like for your kids, are obviously, it's important to figure out how many seizures have they had, how long is the longest one that they've had, is this typical for them?
Yep.
Probably not, because they're calling you.
Right.
So there's probably a reason that they're calling you.
Yeah. Medication changes.
Yeah.
Diet, weight changes, things like that.
Yeah. And seizure patients tend to try and they end up with a lot of different medication changes over their course of epilepsy.
Right.
To try and gain control.
Yep.
So they can't have multiple medication changes. But if the patient can't tell you that, normally a family member or a support member can tell you that. Yeah.
We won't dig a whole lot into really any further into medication or medical management of these seizure patients, because everybody's protocols are going to be different according to what service that they're working for. So I would just say follow the protocol that is provided by the service that you work for. But almost universally, that's going to be benzodiazepines to start. So Ativan, midazolam, Valium.
Yeah. And in a more broad way of looking at it, treating what the underlying cause is. There's a lot of reasons why people have seizures, and a lot of that is electrolyte imbalances. So did the patient just run his first marathon and went out drinking afterwards to celebrate, and now they're profoundly dehydrated and hyponatremic, and are they hypoglycemic? There's a lot of endocrine reasons why people have seizures. So hypoglycemia, we can talk about like hyponatremia, so low salt in their blood, hypocalcemia, alcohol withdrawal.
To your point about hypoglycemia, anytime I think about a seizure patient and when I'm documenting it, a good friend, previous partner, and mentor of mine, when I was going from primary care paramedic to advanced care paramedic, I had this conversation with him just regarding seizures and hypoglycemia. And he said to me, make sure that you're always checking the sugars immediately, because your PCR so your patient care report is going to look really stupid if it says 5 of Midaz, 5 of Midaz, 5 of Midaz,
no glucose,
25 grams of DFA.
In that order.
So check the sugars, guys. I've never got that. I thought that was a good point.
I mean, it's one of the main reasons why people have seizures. It's one we see a lot, especially in Nova Scotia where we are. Because we do have a lot of diabetics and a lot of people that suffer from diabetes. And we've got a lot of new diabetic medications that are on the market now, with Ozempic and Jardiance. Like, there's a lot that can cause hypoglycemia. So check your glucose.
Check your glucose. Kids. And calculated GCS, which you
can
calculated find GCS right here. Ding. So in closing, I guess if you were to look at these patients, in the previous episode we were talking about strokes, now we're talking about seizures, how would you differentiate between those two in a patient? So let's put yourself in the shoes of a paramedic. You walked in somebody's house, they're on the floor, it was reported to be a seizure. You don't see any seizure activity. What you see is a patient with their eyes open, but they're completely aphasic. So they're not speaking and they're not following commands. So they have a bilateral arm droop. They're just very weak. They can't say any words, or if they try to say any words, it's coming out garbled and confused. How would you take those findings and say this is a seizure as opposed to a stroke?
Do the symptoms alleviate at some point in time?
Exactly. That's the big one.
Even patients that have what you're describing as like a complex partial or like a focal seizure, that they will go aphasic and that they'll be looking at you the entire time, but it's like the lights are on and nobody's home. That eventually will let up.
Right.
Um,
And that's what I was kind of,
yeah,
uh, I guess I was describing the complex partial, but I was picturing that that patient to be in the postictal phase. So
yeah,
they had a seizure,
yeah,
they had a grand mal seizure,
yeah.
but you've walked in, the seizure's terminated, and now you're in the postictal phase.
Yeah, so this is in the GCS when we have an obtunded patient, we'll say, so
Mm-hmm.
somebody that's like not really responding,
Yep.
and then which is why I kind of said it. The other one is that motor response is really important.
Mm-hmm.
So in this postictal phase, when they can be lethargic or agitated, you're assessing, you're
Mm-hmm.
looking.
Mm-hmm.
Are they moving both of their arms
Right.
in their agitation? Are they moving both of their arms? Are they moving both of their legs?
Mm-hmm.
If they're completely flaccid and flat, when I give them a trapezius squeeze, does that arm come up? When I give them another trapezius squeeze on the other side, does that arm come up?
Right.
Do they withdraw from pain?
Yep.
Because if this patient had a seizure because of a stroke, and I'm dealing with a hemiparesis or a dense hemiplegia on one side, then they're still going to respond,
Mm-hmm.
right, to my painful stimulus, which
Mm-hmm.
is the nasty thing that we have to do in neuro assessment in order to see how somebody's functioning.
Yep.
But pain is one of those very basic things that our brain responds to, and that's why it's so important
Yep.
in our neuro assessment. So you're not going to figure out anything during the tonic and clonic phase.
Mm-hmm.
You're just supporting the tonic and clonic phase.
Right.
And then after, in the postictal phase, if you don't have to deal with agitation, because that's something else that may generally happen and which will generally also subside,
Mm-hmm.
you can only do what you can do. So you're looking at limb movement, you're looking at arm movement while the patient's moving around and you're trying to get control of them. And again, it's not a patient that's going to be able to do what you're asking them. So your objective is to observe.
Right.
Um,
Observe
and
and manage that airway
yeah,
and
observe,
breathing and
manage the airway.
the foundations of care, I guess we
Yeah,
can call it.
and get them on a stretcher and get them to where they need to go.
Mm-hmm.
Because if it's going to happen again, it
Mm-hmm.
might happen again.
I would add in this setting, because in the
Please.
last episode we talked about not delaying transport for
Mm-hmm.
things like IVs
Yeah.
specifically. I would say if you're encountering this specific patient and you're still in the house and they're in the postictal phase, they don't have a history of seizures, this is a first time seizure,
Yeah.
this person absolutely should go to the hospital.
Yeah.
It's not hypoglycemic, there's no reason to leave this person at home.
Yes.
Then the best time, in my opinion, and based on my experience, to start an IV on these people is in that post seizure or postictal phase.
Absolutely.
Sneak it in there, just get it done, because this is a very traumatic thing for them, especially if it's their first time. And as they wake up out of this, they're going to be confused, they're going to be embarrassed, they're going to be agitated, they may be aggressive or violent.
Yeah, absolutely.
And they may need more medication support for more seizures.
Mm-hmm.
So you always have to be worried about, if it's a first time seizure, if there's going to be another seizure immediately following it, you need to be able to manage that with medications.
Yeah. And I think a really important thing to mention, especially for somebody that's being reported as a first time seizure, is like we need to rule out trauma.
Yeah.
We really need to rule out, was this a fall? Did they hit their head when they had their first seizure?
Yeah.
So hopefully that there's somebody there that can either give you that information or you can get that information from the patient.
Yeah.
But we do really need to rule out trauma. Because again, like we talked about in the last one, strokes, hemorrhagic strokes, they can all seize as well.
Yep.
So yeah, that's when we're kind of differentiating between this is a medical thing or this is a traumatic thing.
Yep.
We have to we definitely have to worry about infection as well. So I mean, I think it's important to get a temp on these guys at some point in time.
Quite often they're going to be hyperthermic post seizure.
Yeah.
It takes a lot of energy and a lot of, it's muscle rigidity, and we know the byproduct of using energy and ATP. If you go back to that textbook sciencey stuff, the byproduct of that is heat. Yeah. Right. So they're going to become hyperthermic post seizure.
Mm-hmm. Yeah, it gives a little bit of information to the receiving facility. because we also have to worry about like CNS infections, meningitis.
Mm-hmm.
Like these are all things that
Yeah.
can also cause seizures. So, you know, looking for your, do we have a rash, like an
Mm-hmm.
unexplained rash that's developed over the, because that can be one of the telltale signs of like a meningitis or a CNS infection.
Mm-hmm.
Um, so again, not to belay the, the sample history,
Mm-hmm.
but it is important because
100%.
it gives you just so much more information
Yeah.
on what you're going to be treating
Yeah. Well, that's why,
when we get there.
I think everybody learns at the very beginning of their healthcare career. So I can only speak for paramedics, but certainly as I entered paramedicine as a primary care paramedic student, sample history,
Yeah,
OPQRST, that's all
yeah,
it's hammered into you. And every scenario you do, every simulation, every conversation you have about those things is rooted in sample history
yeah,
and OPQRST.
and
And
that's why it's called the basics.
yeah,
Yeah, because
absolutely.
it's
Get
the
really
base.
good at that because you're never gonna get rid of it as long
No,
as
no,
long as you're in
absolutely.
as long
Yeah,
as you're in
it's going to
healthcare,
be a
it's
long time.
it's gonna be there. So
Yeah,
get good with it, get comfortable, and
yeah,
understand how to apply it.
totally.
That's awesome. I appreciate that. That was a good conversation
Yeah.
surrounding seizures, grand mal seizures specifically.
Yes.
If you guys want to dig deeper into other seizure types, you can find Steven's number right up here. No, I'm kidding. You're not getting
Please.
that. And yeah, hope you guys all enjoyed that. And
Yeah.
make sure you subscribe. Check out the other content that's on here. It's building slowly. And as it builds, hopefully we can tie subjects together and reflect on some of the other pearls and principles that we've learned and apply them to these conversations.